Okay, well, it is 4 o'clock, so we will go ahead and get started. So welcome back, or welcome if it's your first time, to our second session of our Diabetes and COVID-19 Empowering Patients. Today, we are really focusing on creating powerful partners. Please welcome the rest of my staff here at Mount Pacific Quality Health. So I'm Caitlin Conway, and also joining me is Crystal Morse, Patty Kasednar, and Stevie Sy. We are also very fortunate to have Carolyn Renner today, registered dietitian and consultant at Nutrition Works. And so she is going to be sharing a lot with us today. I also wanted to share that it's National Diabetes Month. And as stated by the American Diabetes Association, which we agree with here, it's time to take action together as a community, because together we can conquer this disease. Together we stand greater than diabetes. Next slide, please. So at the end of this, these are the same objectives you saw last time, but I just wanted to touch base on them again, that we have these same 4 objectives for this 4-part series. And during our first one, we discussed the COVID-19 related current events. We'll work to share and identify best practices for diabetes identification and management during this pandemic. Implementing quality improvement projects designed specific for diabetes diagnosis, and of course, engaging and empowering our patients to foster continued health participation. So before we dive into today's content, we here at Mount Pacific want to thank you for all you do to work with and for our patients, our families, community members, coworkers, and others. We know the weight of this pandemic can often seem so unbearable. Our gratitude for the compassion and passion you display in a day in and day out, and your unwavering care is not going unnoticed. We are so thankful for you adding even more to your plate, as you are also being family and friends to the patients when they're unable to see their own. With the fatigue and the stress, whether it's physical, emotional, mental, and spiritual, we want to remind you that your own self-care and resiliency are equally important. Our hope today is that we're able to share small acts of change that can be incorporated to your already over-demanding workload. I want to thank you for taking care of all of us. I will now pass it over to Stevie to share some updates on what's happening within our region.
Thank you, Caitlin, for that intro, and also for the reminder that we all have to put on our own resiliency mask first and make sure that we are taking care of ourselves so that we can really take care of our community. I am going to dive into our COVID-19 regional update. Just some past week United States all data for you guys. According to the Washington Post, our new daily reported cases rose 17% over the last 7 days. New daily reported deaths rose 14.6%. Our COVID-related hospitalizations rose 15.1%. And among reported tests, the total positivity rate is 7%. So remember, that's that number that we are tracking longitudinally to see how big the outbreak is. It's been widely reported that there is no epicenter for the current outbreak of COVID-19 that we have in our country, and that's because it is very widespread. The number of reported tests did rise 4.5% from the previous week. The rise in positive tests is not related to the rise in reporting. If we were just increasing testing without increasing the number of infections, that positive rate would drop as we increase testing, because that's our top number in that fraction would be the number of positive tests. The bottom number, which is our denominator, would be the total number of tests. We're not seeing that the total number of tests is diluting the positives, so we do know that we're trending up nationwide. Next slide, please. So we have our Alaska and Guam snapshots here for you. It is Friday the 5th in Guam. So we have Friday the 6th rather in Guam. So we have their Thursday numbers on there. You'll see that new cases, total active cases are up across a large percentage of our region. We're definitely seeing an increase in hospitalizations. That's definitely the case for Alaska and Guam. And unfortunately, we're really still seeing incredible rises in the number of deaths we're experiencing. That 7-day average for Alaska is below that national average of 7%, but is at 5.74. Next slide, please. So here we have Hawaii and Montana. Hawaii did a really great job of closing down their state a couple of months ago, really getting control of their outbreak when they started to see it tick up. They're still keeping the reins on that. Their active cases did fluctuate a little bit over the last 2 weeks. It's up to 3,500 active cases. Their hospitalizations are coming down. We are still seeing the death rate tick up because there's a lag when people are diagnosed with COVID to when they get sick enough to lose their battle to COVID. So we will continue to see those deaths tick up in Hawaii as they keep control of their current outbreak. Really great lessons to be learned from our partners in Hawaii about how to save lives in our communities and how to prevent transmission. They've done a really good job there. Montana is not in the same place. They are very much seeing new cases tick up rapidly. So when we look at the slope of the chart of new growth, those are becoming more and more vertical, which means we're adding new cases rapidly every day. Hospitalizations is really going up rapidly, and we've seen a lot of new deaths. This is both because we are catching up with those active cases and new cases. People have been sick enough long enough to lose their battle to COVID, but also we're starting to see some capacity issues, which absolutely can impact the death rate. You can see that Montana is well above that national average of 7% in their 7-day positivity rate at 18.25%. Next slide, please. The Northern Mariana Islands are one of our glimmers of hope in our region. They have no new cases. They continue to maintain their very low death rate. They've only had 4 cumulative hospitalizations. The Northern Mariana Islands and American Samoa have both done an excellent job maintaining control of their borders, being very aware of any possible transmission as people move in and out of their territories. So really good news there for a group of people where resources are limited. So it's very important that we keep those rates low. Wyoming is just south of the border of Montana. And so you'll see some really similar trending. That whole area of the United States, Montana, Wyoming, Idaho, and both of the Dakotas are really experiencing a large surge. They did not experience a large wave at the beginning of the pandemic, and they're absolutely catching up now in the fall. Wyoming has led the nation twice in the last 2 weeks in the slope of their new cases. So the number of new cases they're adding per day has been record-breaking for the United States twice in the last 2 weeks. And their 7-day positivity rate is 29.19%. They're also seeing a large number of new hospitalizations. Capacity issues are becoming a problem. Next slide, please. This is our snapshot of per 100,000 residents so that we can all compare apples to apples. You can see that daily case rate per 100,000 is pretty high still in Guam, which has consistently been a problem. And then Montana and Wyoming are also really noteworthy right now. We base a lot of things in life based on our population. The number of hospital beds we have is impacted by that. The number of clinics we have. A lot of these areas have healthcare shortages in general. If you practice there, you already are well aware of this. This is what we worry about when we talk about COVID-19. So those are things to keep an eye on. And then our death rates are continuing to climb, obviously. We don't have a lot of new treatments and options for people who contract COVID-19. We are getting a little bit better about keeping people alive longer. So those death rates will tick up as we do cumulative tracking. The total case fatality rate for the United States is coming down though. At the beginning of the pandemic, it was right around 4.5% for a case fatality rate. Now it's closer to probably 2.5%. That's still significantly higher than influenza, which last year was right around 0.02% to 0.2% case fatality rate for influenza. So it's about 10 to 100 times more deadly than the flu. But we're seeing that death rate come down because the population has really shifted as to who is being infected. We are primarily seeing infections in children under the age of 18, and then also our 19 to 44-year-olds. And thankfully, those folks are at lower risk of fatality from COVID-19. However, they are still at risk for morbidity, so complications from the disease. Next slide, please. I wanted to give a little snapshot here about some of our capacity issues that we should be aware of. Many of the states are reporting what's going on in our hospitals. This is a snapshot from Montana. Those states, counties rather, that are closer to red are at or near capacity for their hospital beds. We are working to flex and bring in more facilities, but you can see in those harder hit counties, we are really starting to see capacity issues. Next slide, please. This is a similar snapshot for Wyoming. This is our trend over the last 30 days. I keep talking about slopes. You can see on that right-hand side, when we look at our total COVID patients in the hospitals, it's really ticking up. It's moving up pretty rapidly. We're concerned about that slope because we have to bend that curve, just like we talked about the entire pandemic, or we will exceed our capacity. There are some good things there, though. We're maintaining access to ICU beds. Most of our hospitals are working to add additional beds outside of ICU to deal with those COVID patients, looking outside the box to treat them and take care of them. We're seeing a lot of good adaptations right now, but we're seeing some fatigue coming in behind and concerns as more staff members are out sick. So we'd love to hear from all of you about what your big concerns are for your communities. Feel free to chat them in as we go through our talk today. Next slide, please. We've been talking about Guam and how hard hit they've been, but we really haven't dug into what that means for them as a community. So I wanted to pull out this quote that I found in a news article from Guam. There are capacity issues in most of our states and territories throughout the United States as this pandemic ramps up. But Guam is really one of those places where they can't pull in their neighbors to help. They're very isolated on their island. And this is a quote from their Guam Memorial Hospital administrator. She's saying that they've converted their urgent care clinic into inpatient COVID beds. They've moved their outpatient specialty unit into their COVID clinic. They're using the gift shop now to do their outpatient rehab services. A lot of big sweeping changes are happening to occur as we flex to accommodate the number of people who need us during this pandemic. Everyone with COVID probably needs to be seen. If they're symptomatic enough to know they have it, we probably need to assess them and keep an eye on them because they can deteriorate. And so this is really a concern. Guam Memorial Hospital has worked very hard to expand their capacity. They're certified for 161 beds. Their current census goes well above that. They are trying hard to adapt. They're bringing in some FEMA money to help bring in traveling staff because, again, that staffing issue is a big concern. So there's definitely a need for support there. I just wanted to bring awareness to what it looks like to be a healthcare provider on Guam right now, and thank everybody who's joined us from there. And let us know how we can help you. And if there's any information you need to learn from some of these places that are experiencing this, because even in the midst of this struggle, we're learning a lot. There's a lot of good things that can be shared, and we need to rapidly roll that information out to everyone. Next slide, please. So that's our COVID update for today. And now I want to talk about leaving an action from our last session. And how did you do? We're going to go ahead and we're going to pull up a polling question here. I can see it on your screen there. And we just want to see, we asked you to do 3 different things as you left us last week. Were you able to share something you learned after the first session? Did you identify a data source where you can identify your high-risk patient population? And then did you verify that you have a standard diabetes protocol in place? We want everybody to practice going back to their practice and working on these things so that we can continue to move forward on our journey of excellent diabetes care. So please go ahead and respond to that survey. I see a couple of you are starting to tick those in. So we'll give that a few minutes while you all put in your responses. We'll give you about 10 more seconds. Okay, we can go ahead and wrap that poll up. It looks like a good 70% of you did go back and report something you shared with your care team. So thank you for that. I hope it sparked some good conversation. It looks like about 60% of you were able to identify your high-risk patients in a data source that can help you do that. And then only 50% verified that you have a standard protocol in place. Another 30% have that in progress. So that's something that we're definitely going to come back to in our next session here in 2 weeks, because that is really a key piece to getting us started when we're looking at good diabetes care. So we can go ahead and close the poll and move on to the next slide, please.
Thank you, Stevie. This is Crystal speaking now. I'm going to talk to you guys about empowering patients and caregivers. So here at Mountain Pacific, we bring our patients and caregivers and advocates together through what's called a Patient Family Advisory Council, or PFAC, assisting our healthcare community to the delivery of better care. The council provides feedback and suggestions to enhance our quality improvement initiatives. Patients, families, and caregivers no longer are considered visitors, but team members. To say the least, we are humbled by the dedication of these individuals. Next slide, please. I just can't say it any better than our CEO, Sarah Medley, and with her influence is the way we do business. With the addition of patient family advisors, the care conversation shifts from what do healthcare providers need to do to the patient, but to what do patients and families need from healthcare providers. With this paradigm shift, we have seen the growth and development of our advisors, creating the opportunity to be part of the solution. Next slide, please. Patient and family engagement and patient activation can be easily interchanged, and it's important to know the difference. Patient family engagement, or PFE, has become a cornerstone of patient safety. PFE involves collaborating with providers, patients, and families of all ages at all levels of care and in all healthcare settings. It is essential to patients' health and well-being that everyone work together as partners. And patient activation emphasizes patients' willingness and self-confidence to take independent actions to manage their health care, ultimately creating better health outcomes. Next slide, please. It's simply disheartening to hear our advisors' perception that the system was created to break us. This is a snapshot of a 2-page discharge summary that was shared from one of our advisors. It's obvious that this is a universal form used for both clinicians and patients. Without a medical background, this is very difficult to interpret for the patient and/or caregiver, creating communication barriers, the incidence of medication errors, and the unease of how to care for themselves at home. Next slide, please. So I wanted to share some statistics with you. 41% of family caregivers say they don't have enough information to support their loved ones in chronic care management. And on the flip side, when families and caregivers are involved, the likelihood of hospital readmissions is cut by 25%. Next slide, please. I can't emphasize it enough. The patient voice is so valuable. Patients can help improve safety by participating in quality improvement methodologies. Advisors can help redesign the systems to improve processes that are necessary for the overall patient experience. As they put it, teach us, trust us, and set us up for success. Next slide, please. Patients and families can participate in all care settings. They are able to view things through a different lens that we don't always see. Their personal stories represent a true picture of patients and what they need. They challenge us to take a step back, listen, and reevaluate different approaches to the why, and shifting our thinking of, we've always done it that way. Patients and caregivers provide educated perspective by bringing authenticity, respect as part of the care team. In time, patients become empowered as a team member, educator, speaker, listener, advocate, collaborator, and leader, ensuring the focus of our work is patient-centered. Next slide, please. And Patty, I'll hand it over to you.
Thanks, Crystal. So as Crystal shared, the voice of the patient is very valuable. So where can you get some feedback from your patients? So we thought we'd share a couple of examples of that. So as Crystal mentioned, a PFAC, or a Patient Family Advisory Council, is really composed of your patients and family advisors who you recruit out of your pool of patients to work with interactively to identify opportunities for care improvement or quality improvement. And then there's patient satisfaction surveys. Now, any organization can sponsor their own surveys, create their own questions, go after specific data that they might be interested in. But there's also CMS standard surveys for both inpatient and outpatient settings. And here's just really some examples of the information. Now, there's a lot of questions that are asked in each of these surveys, but we kind of pulled this out to give you an example of some of the topics that are discussed in those surveys. And I really wanted to point to the Agency for Healthcare Research and Quality. They actually have a whole section of their website devoted to improving patient experience using survey data. So if you can find your survey data and you identify an opportunity for improvement, there's a whole website with tools and plans and half of the work done for you. So I just wanted to make you aware of that resource. So we're going to have our second polling question here. And the question is, do you actively use patient and patient advocate feedback to identify improvement opportunities in your organization? And if you do, the second part of that question is, which ones do you use to do that? So if you could just take a second to go ahead and answer the poll, that would be great. Okay, come on, folks. Only 7 voted. A couple more minutes. I know that there's several quality programs that require you to have a PFAC, and they're actually scored on your patient satisfaction surveys. So my guess is a lot of people are using them. Okay, thanks, Mary. I think we can share the results there. And it looks like quite a few are doing that, and quite a few of you have an advisory council. So congratulations on that. That's great. Okay, you can stop sharing that. That's fine. Thank you for participating in that. So what we went to the Mountain Pacific PFAC, or Patient Family Advisory Council, and I met with them in September, and I really asked them what their input is from a patient's point of view. What would you like from your care team? And the feedback we received, you can read it here. I'm not going to go through them all, but really basically everybody wanted to be treated uniquely. And the universal feedback, and really to us, meant meeting patients where they are at in their healthcare. So if you think about that for a minute, we'd like you to put in chat, when you think of meeting patients where they're at, what is the first word or two that comes to mind when you think of that? So if you wouldn't mind chatting that in, that would be helpful. So everybody, my co-presenters, I'm unable to see chat at this point. So if you could monitor that and provide feedback if it makes sense at some point. So the patients, the feedback that we received from our PFAC really helped point to some patient support tools and ideas that you could incorporate into your organization and your workflows to improve patient engagement and activation. Now, a lot of these have methodology behind them, and it feels like, especially now in the current situation that we're in, that like we can't do one more thing, which feels really overwhelming when you think about it that way. But if you think about the one word you thought of when you thought of meeting patients where they're at, each one of these probably has an element of that in them. So I just wanted to encourage everyone that even small changes can make a really big difference when it comes to patient engagement.
Patty, I'm going to hop in real quick and let you know from our audience, the one word most people thought of was listening. We also saw empathetic and respect. So I think we all have a good feel for what that means from our side of things, and it's nice to see what patients say as well.
Nice. So we have our next polling question. So the question is, are you using any of these these methodologies to help support your patients? And if you want to answer all that, apply. So the teach back techniques or shared decision making, motivational interviewing, if you can really just take a second to fill out all of them that apply to you, that'd be great. And really the reason we are collecting this data is it really helps us create ongoing education. So if we can help identify where the need is from these polls, it really helps us create the agendas for the following sessions. So we really appreciate your help with that. And we're going to just leave it open for about 10 more seconds. All right, Mary, if you want to close that out. And appreciate that feedback. Oh, a lot of shared decision making. That's really great. All of that work is really great. Thanks so much for that. So we talked a little bit about the things that you can do as the care team, but the patients really have a role in it too. And as Crystal mentioned earlier, activated patients are really those who have the skills and confidence to become actively engaged in their health and their healthcare. And we know from the data that highly activated patients have better health and better health outcomes. So as a care team member, possibly one of the things that you can do to help increase their activation is educate them on what their role in self-management is. And some of these are really very basic and very easy, but it really does help when the care team provides that feedback for the patients as well. And then one more question, and again, this really helps us to drive further education. So we're just asking if you would be interested in joining a patient family engagement and a patient activation affinity group, because really what we'll do, what these learning and action events allow us to do is break off into small groups of quality improvement projects. So if you're interested in any of these, please indicate that on the poll now. Okay, we have 2 people voting. Any other feedback from you folks? It would be helpful. Okay, why don't we finish that up, Mary? And it looks pretty even across the board that interest in a lot of those different techniques. So thank you so much for sharing that with us. And then I'm going to turn this back over to Stevie.
Thanks, Patty. So I just wanted to talk to everybody real quickly again about data, but this time what it looks like when we empower and activate our patients and how that translates into success in clinical terms. So if we can move to the next slide, please. So this study, we've got a little snapshot of results here, but it was conducted by Tang and some of his associates, and they looked to assess a lifelong diabetes self-management intervention So very similar to our diabetes self-management education that we provide now as part of DSME. And they looked at what happens when we design a program around the basis of patient empowerment principles, where we view diabetes as a patient-managed disease. We emphasize the patient rather than the provider as the ultimate decision maker. And then we recognize patient-selected goals and know in our hearts as clinicians that they have a greater likelihood of being achieved and sustained. So when we let patients tell us what they want and how they want their disease, what they're willing to give in terms of controlling their disease and where they feel like it could impact a little more, when we let them make those choices, we have better success. So study participants were in an 88-week series of sessions. They lasted an average of 88 minutes over the course of 24 months. So really a long program here, very similar to our 1 year that we like in a diabetes prevention program. And what we found is at the end of 1 year, we find that they have better glycemic control statistically. We know that's tied to this intervention. They have lower cholesterol and they have lower low density lipoprotein cholesterol levels. So all things that we track clinically. And then at the end of 2 years, we find that people who self-select to follow a healthy diet, who go through these programs, are better able to stick with those lifestyle changes even after 2 years. They learn to space their carbohydrates more evenly across the day. They're able to use their insulin as recommended because they understand the why and also the how, right? Because we've taught them things like how to get access to your insulin, how to store it. And then they also achieve diabetes-specific quality of life. Fewer days in the hospital, fewer days sick, better able to participate in those activities of daily living that are important to them. So really powerful stuff there. So with that in mind, we say that to cue you up to talk with Carolyn, and I'm going to pass it briefly back to Caitlin so she can tell you a little bit about Carolyn.
Awesome. Thank you, Stevie. So please join me in welcoming Carolyn Renner. She's a registered dietitian and nutritionist at Lander Medical Clinic and Western Family Care. She received her BS in home economics from the University of Wyoming, and then she completed her internship and MS in nutritional science at the University of Michigan. She consults with individuals, hospitals, healthcare facilities, state agencies, and corporations. She empowers her clients to make changes to meet their goals. Carolyn, I invite you to share your experience and techniques that have aided in activating your patients. The floor is all yours.
Thank you very much. So I'm going to be talking about the area that I live in Wyoming. It's Fremont County. It has Lander, Wyoming, and it has Riverton, Wyoming as a part of that. We have a large population of Native Americans that are also in Fremont County, and the total population is 30,000 in the whole county. And right now we have 1,636 positive tests that have been positive. We've had 18 deaths. I know of a few more because we're lagging in the time, and that happens. And this is just in our county of the deaths. In Sage West, the hospital, they have in Lander 89 beds. Riverton has 159 beds. And that means that we couldn't take a lot of people at one time. We were shipping more off than we are now because our hospital was really full. We were hit hard and hit early, as you can see there. And that was really hard on everybody in the hospital. And to talk about the vulnerable populations that we had, they were the elderly, because the elderly are malnourished prior to admission, even when there's no COVID. I mean, that population does not eat very well. 6 in 10 elderly people are malnourished in our country. So they're already coming in malnourished, and now COVID doesn't help them out at all. And they have poor outcomes, unfortunately. So we saw the Native American population was the largest we were seeing when we first got or had COVID in March. And people with diabetes and obesity, those ones are the ones that did not have the best outcome. And then we also had more patients that were vented. Now we don't have that many patients that are vented. We've changed the way we do business because we're now learning more about the COVID patient and what we need to do. Because initially everybody was just pulling it, straws, trying to figure it out. And I'm not trying to be disrespectful. I think I have great healthcare here. I would go to these people if I had an illness or a sickness or COVID included. It's just that no one knew. I mean, we're still learning so much about COVID. And so initially we had more of the in our Native American population in there. Well, now we're having more of the 40s, 30s, 50-year-old population, and they're of Caucasians. They're from our community. And actually, we all have been talking about it recently, going, we know their names now. Before, we would see people that were just in the community and we didn't know them necessarily, but now they're our friends, you know, they're our friends' children. And then that's really hard because we all now know that they had a state soccer tournament. It's almost been 2 months ago, I guess. I can't believe we're in November, but we are. So we had a soccer tournament here, and there was a ton of little kids from all over the state of Wyoming. And those little kids inadvertently took it back to their communities, so that we're seeing a rise in the numbers. We've seen the rises here. We've had teachers out, we've had students out of work. I mean, they're out for a long time. I also work in a nursing home, and we have staff out. We have several staff members out right now. And we're changing how we're having to do things now. 2 weeks ago, we were able to have patients have their family members come into the hospital, and they were coming into the nursing home, but sitting outside 6 feet away. That's all stopped as of last week. We unfortunately had some nursing students that were sick as well, because they were, you know, taking care of the patients. And then they went into these buildings, and now we've shut everything down. So, and I myself, even believe it or not, I normally get to go in there, but from March, as the dietitian, from March all the way to July, I wasn't allowed in there. I was allowed to do electronic submission of the assessments, which they need to be done. And I know people probably think, well, that's okay. What does dietary mean to them? Anyways, it's like, well, at this point in time, malnutrition is the #1 thing that is occurring in our patients, and the doctors are more aggressive about nutrition with our patients, and they are losing weight, and their outcomes are not that good. So initially, it is important for me in my job to come out and take care of these patients, but I can't even physically see them. So I have to depend on my dietary manager to give me the eye assessment kind of thing. So it's changing, and it keeps changing what happens right here, right now. When we were talking about the uncertainty that's occurring, initially, the doctors really didn't know what we were to do. They were doing the best that they could do. And we vented a lot more patients, as I said earlier, and now we're not. And we've shipped a couple out in the last 2 weeks of vented patients, but we're holding them longer so that we can see, you know, how the oxygenation goes on them. And if it goes down too far, then we need to send them out. But right now we're also finding around the Wyoming area, the other hospitals are not wanting to take our patients. And it's not just because we're in Fremont County and have vents. That's probably, you know, people would want to send them from Gillette to Casper. They don't want to take our patients. They don't want to take patients. They can't. They're overwhelmed again because of this new resurgence that we had. And it's hard on the staff, and it's hard, I mean, obviously, on the patients as well. When it came to the staff burnout, though, the staff right now are really more vigilant now. But there was a period where when we first got it, we were scared to death and didn't know what we were doing, going to the doctors, asking questions, and the doctors are saying, we really don't know, but this is the best to do. And it's changed on our PPE over this whole 8 months of COVID. It's changed, you know, what we need to wear, and we're learning more. And unfortunately, some of that was trial and error. And unfortunately, that I myself was exposed several times to patients with COVID. And I have had it again, and I've had to have the 14 days at home. But some of that was that we didn't realize that we were exposed from, like, the nursing students that came down to the nursing home. You know, we didn't know they had it. And we find out a few days later, now you get quarantined because you were near them for 15 minutes or more. So that's really hard. And even on myself, I'm like, oh my goodness, I don't want to be quarantined again. It was the hardest thing ever. I got to learn what people during this lockdown that they somewhat had, I guess you call it. We were telling people that they needed to stay home, that we had. I worked through the whole thing as a dietitian. Our nurses worked through the whole thing. The dietary staff, we're talking housekeeping staff, everybody's been working through that. So we didn't really know what it really felt like until I got quarantined. I never have had it. I haven't had it. According to current standards, they said it came out in February. I think the majority of the people in our hospital tell you that they had it prior to that, but and that's okay. So the staff in themselves, in the beginning, we were all somewhat scared. Then we got a little lackadaisical in June and July. You know, they're just, you know, it's not going to hit us, you know. And I think you could see that even in the news. You'll see where people are not wearing their mask like they should be wearing. And then all of a sudden, now we're having more cases. We have to start wearing our mask and our PPE. And the staff really, when they come in and a patient comes into our hospital, I can tell you they really, really care for that patient. The hardest thing they have to do is try and care for them through all of this PPE. And you don't have the best relationship with these patients because they don't get to really see your expressions. It's just your eyes. And in the population I work with, some of the elderly really don't want to talk to you because they really don't trust you. And I'm not trying to be mean. They're just like, what are you saying? What do you need? You know, and you try and tell them, but your mask is on your face and it's reverbing back at you. They can't hear it. You want to rip your mask off so you can talk to them, but you can't. And some of the elderly, you know, they want to reach out, hold your hand. Of course, we're in PPE, that's fine too. But they're also asking me as the dietitian, can I call their son or their husband and talk to them? Because guess what? They get no one there. So those patients become more malnourished as well. The staff is doing everything they can to have a good relationship with them. But when you start seeing people die like we did in the beginning, you didn't even get a chance or a breath to recover from that, because normally, you know, you'd have a death every, maybe every month. You know what I mean? It wasn't that much, but now, and one is too many, I'm not saying, but now when you're having 13 to 18 deaths in the last 8 months, and they're COVID related, it's really sad. And it's really hard on that. And psychologically, it takes them out. And they have been giving offers of mental health to our staff. Like I said, now some of our hospital staff, our nursing home staff, they're out with COVID, and that's unfortunate. When it comes to the malnutrition, like I said earlier about our elderly population coming in, they already are malnourished. And just so you understand, it's the imbalance intake of protein and energy and for a prolonged amount of time. There's an undernutrition as well as an overnutrition. A lot of people will think that people with the BMI over 30, which is obese, which that's the one we're seeing is vulnerable to COVID as well. They'll say that, oh, they're overweight. They can handle it. You know, they're going to lose some weight anyways. No, that population I really need to watch, because people think that they're, you know, got enough stores. Well, inside their body, when we do their labs, they're not nourished well. And I mean, the way that we handle these patients is now we make sure that they get either 2 feedings immediately, or obviously I'm in there and consulted more. And I used to go in maybe once every 2 weeks to the hospital. When March it came in, I was going in every day all the way into July. Then they backed off a little bit, and now I'm going in there every day again. We have so many patients that are COVID positive, and they're seeing the importance of me getting in there and talking to them. I mean, it's a dietitian. I mean, the nurses get to see this. That's one area that they're glad they push off onto the dietitian at this point in time. They're just like, let me take care of these patients, because putting on all the PPE and going in and trying to care for them, and the alarm's going off, you have to put it back, the PPE back on and go back in. They're just burnt out. They're just tired. So, I mean, and I need to be there to make sure these patients get adequate nutrition. With COVID, they're saying that there's a significant impact on malnutrition and the health outcomes, meaning some patients are dying because of the malnutrition, and they usually get malnourished prior to admit, because when I admit them, there's this pretty much a criteria for me to diagnose malnutrition as a dietitian, and then I go to the doctor and tell him about the malnutrition, and then he puts it in the chart. So we just talk about what malnutrition is, and we make sure that everybody understands it, and we get the best care for our patient with that. And the malnutrition is truly causing the outcomes to not be as good. And I've seen readmissions due to it as well. And that was just before COVID, we'd get readmissions with malnutrition, but now we're seeing more. With COVID, they're having fevers, their cough, shortness of breath, muscle aches, confusion, headaches, sore throat, chest pain, pneumonia, diarrhea, nausea, and vomiting, and loss of taste and smell. And I honestly see all of those in every one of those patients. I have to treat them differently. Is there anybody there?
Oh, yep. You know what? I did that. I stopped share. Sorry.
I was like, whoop, I saw something. Did it go out?
Yeah. I do need to tell you, we're probably only have about 5 minutes left for you.
Fine. That's fine. That's good. I got it.
Yeah.
So right now
we're.
What was that?
Is it back on the screen? Am I sharing?
Yeah. Yes.
Okay. Sorry.
So yes. So the malnutrition that we see, that's difficult, and we have to make sure we treat it and take care of them in order to have a better outcome so they don't get readmitted. And then we're talking about the after COVID care on that. What happens with that, and now we've found, and it's taken us 8 months to understand, is if a patient comes into the ER and their O2 sats, their oxygenation, which is supposed to be at 95 to 100, is low, there's a point where you have to make sure they get them oxygen and bring them into the hospital. But some patients are coming in with the symptoms of not necessarily the breathing issues. So right now we're giving them an oximeter to go home with and a spirometer to go home where they blow into it. We give them an information handout on nutrition, even though they don't want to eat. We tell them how important it is, and to get some exercise. And even though you're sick, you can still get off the couch. You can get off the couch, and that's what they want you to do, because what they have found is that patients that sit on the couch, the saturation looks like it's up and they're doing fine. But the minute they try to get up to go to the bathroom or otherwise, then it's too low and they're sicker coming in. They're waiting longer to come into the hospital. And so we really need to have follow-up. And actually we have the chronic care management that follows up with them. But for myself, I also call the patients. And if they've got COVID positive, I will not go into their house, but engaging my patients now takes me to the point where I have to call them. I have to do telehealth with them. And I have to make sure that my co-workers are knowledgeable of it as well, because it's not just the dietitian. I mean, they've got the physical therapist. I mean, these people are so malnourished and debilitated that they're saying the long-term issues that they're seeing with COVID is not just when they get ready to go home from the hospital, oh, they're better. No, it takes months and it can even take years. We don't know the final on that. That's just some preliminary information on it. And usually the lungs, the heart, the brain, all of those areas are affected by COVID. And that's why proper nutrition is so important. When I talked about the home visits and telehealth, actually for my National Diabetes Prevention Program, I have an app, but I also have it for my normal patients as well. But for the National Diabetes Prevention Program, I have an app that is called Healthy. And I actually have one-on-one contact with my patients. And I'm also doing that with my patients that have COVID from the hospital. I give them calls, or I actually let them have the telehealth. They can see me, I can see them. But it also, they get to interact with me as a healthcare provider. And sometimes I find that patients aren't doing as well as they need to. I can send them to chronic care management. I had 2 yesterday that I sent off to chronic care because, you know, they just don't, they're shut in. Our patients are truly not having the best experience, the elderly population or the people with diabetes. That's why I like to use my app that I have. And I think that's what we need to do. We need to talk to our patients. Again, I heard you guys earlier saying about listen to what they want, but we also have to listen to them and make sure that they're healthy and they're making good choices. If not, you have a concern, then you can talk to your doctors about it. With my diabetes prevention program, I have to tell you, I'm having a nice time with my patients right now. And it's one of those that we challenge one another. And actually this week I talked to them and told them that we're really trying to get patients to be more active, even if it's just walking around the block, so that people that are active, it affects your lungs anyways. But those are the ones we're finding that have a better recovery if you've been active. That's what we're seeing right now. So other than that, I think I went through all of it. This one,
on this slide?
What was that again?
Anything for this slide?
This slide is actually about the healthy, about the engagement with the patients and accountability. That's why they come back online, and I set the goal and say, this is what you need to do. And then they'll go back in and they'll document what they're doing. Again, it says it has, it's the improvement for the patient outcomes. That's what we're looking for. And even in the COVID patients going home, we still need to follow up with them. And that's how I can do it. And communicate anytime. So we're good.
Good. So what we wanted to do this time, I think, Caitlin, are you providing the directions here?
Absolutely. So thanks, everybody. We are going to now be going into breakout rooms. So you will automatically be prompted to join a room. So please click and join into there. We are going to talk through these 3 questions as you see on the board. And so these are going to be open-ended, really an opportunity to network with your peers. And so really in light of all of that Carolyn shared, that was really helpful, I think, as we move into these. So thank you for that. And so with that, Mary will bring us into those, and we will come back with 5 minutes remaining for a brief report out and close out. Well, welcome back, everyone. I see everyone starting to slowly trickle in, so I appreciate that. But everyone, a facilitator or somebody from each group, if you could chat in your kind of key thing that you learned or heard while Stevie kind of closes us out, that would be amazing. And we will be sure to capture all of that because there's amazing feedback in our group. So I want to make sure everyone hears that. So Stevie, back to you.
Perfect. Thank you so much. So for our leaving in action today, again, we want you to reflect on what you've learned, look for things that you can share that you learned today. Be sure and bring that back to your care team. We want you to continue to evaluate those data sources. Look at how does your organization use feedback or data from a patient and family advisory council, your HCAPS or your CAP scores, other surveys. Oh, it looks like we changed. There we go. Thank you.
Sorry.
You're fine. And then do you use patient satisfaction surveys? And then lastly, we want you to look at with patient engagement. We'd like you to identify one new patient engagement tool or idea that you can implement in your organization. So there are lots of good things happening in chat. Feel free to add those things in. Just to summarize a couple of things. We've heard that it's good to have an active, positive environment. Being creative and being active is super important to being successful right now and engaging patients. Looking for more telehealth. And then it looks like there were some self-care strategies that were identified, like exercise, pet therapy, spending extra time with family. So remember, self-care is a practice that we preach. So we also have to implement it as well. We have to assess those risks for ourselves, just like we do with patients. Thanks for Deb Anderson for that feedback. We can move on to the next slide here, please. Our next session is going to be on November 15th, back to our regular Tuesday slot. That will be at 4 p.m. Mountain Standard Time. Please go ahead and send that out to anybody else that you feel like might be interested. We can move to the next slide, please. And then lastly, if you have any questions, these are your speakers today, and we are happy to serve you in any way we can. Please share with us your struggles and your triumphs so that we can help you celebrate and also work through any barriers that are coming through. If something percolates to the top of your mind after you leave the session and you have burning questions, these are your contacts to help you meet those needs. So,
it's November 17th.
It is November 17th, correct? Oh goodness.
Oh, yep, our slide's wrong.
Thank you so much. It is November 17th. Thank you, Karen.
Unless we all want to meet on a Sunday, which I don't think so.
All right. Well, thank you everybody for your time and attention. We appreciate you participating in our breakout rooms, and we will see you all again on November 17th.